we'll get started. Okay, so we have to do 3 things tonight. We're going to talk a little bit about asthma. We'll talk a little bit about abdominal emergencies, and we'll tie that into obviously the geriatric population. And then I was going to say I'll send out the quiz, but I sent it out by accident ahead of time. So the quiz went out. If for some reason you don't get it, I'm sure Pete will resend it out to anybody that I didn't have on my distribution list. Okay. Okay. So we know EMS-wise, probably the vast majority of respiratory calls we go on are asthma and probably COPD, you know, being secondary. There's less COPD patients, obviously, because there's less cigarette smoking. But unfortunately, the cases of, you know, asthma continue. Now, asthma is kind of like a problem with our immune system, just like anaphylaxis is. But the difference between asthma and anaphylaxis is that in anaphylaxis, it's a systemic situation that's affecting the whole body. Let me just mute everybody. If anybody has a question, just unmute yourselves or write in the chat. So anaphylaxis, we know, is a systemic problem where the immune system is overreacting to something, some, you know, bee venom, milk, peanuts, or whatever, but it's affecting multiple systems, your respiratory system, your upper airway, lower airway, your GI system, your skin, your blood vessels, where asthma is pretty much what they call hypersensitive airway disease, where the main reaction in asthma is the actual bronchioles. So your bronchioles, you know, are the lower part of your airway, right? The tubes down low going, and your terminal bronchioles, your smallest tubes, and at your alveoli are your air sacs. And what happens is that they become hypersensitive to some stimuli, and we call those stimuli triggers. And every asthmatic has different triggers. They could have one trigger, they could have multiple triggers, but you know, the typical triggers would be seasonal changes, could be dust, pollen, stress, exercise, you know. So there's a lot of different things that can cause asthmatics to have asthma attacks, and they could have multiple triggers. But when the trigger happens, right, their airways do a couple of things. So your bronchioles are aligned with okay, Matt took the exam already, but he's texting me telling me he was in a different time zone, so he thought it was all legit. But anyway, your bronchioles are aligned with smooth muscle. So your smooth muscle in your body is your bronchioles. So you're actually your entire airway, your blood vessels, your GI tract. Trying to think, I'm sure I'm missing something else. Your GI, blood vessels, lungs, urinary tract. So when the smooth muscles are stimulated, what they do is they constrict, right? So in this case, if your bronchioles have the ability to dilate and constrict depending on the amount of air they need to go in, and now because you're having an asthma attack, they constrict the inside, the lumen of the tube gets smaller, so it's harder to move air through. And whenever you're pushing air through a narrower tube, there's going to be, you know, much more resistance to the flow of air. And that's actually what causes the whistling sound that we hear that we call wheezing, right? Just like if you were to stick your fingers in your mouth and blow air through, you'd make a whistling sound. It's a similar thing that happens with the asthmatic. Now, besides the actual, you know, muscles contracting and making the lumen of the airway smaller, 2 other things occur. So we also know that our entire airway, right, from our nose all the way down to our bronchioles, are aligned with mucus. Mucus plays a role in trapping particles of pollution that should not enter down into our lower airways. So, you know, mucus is a sticky substance, and when it absorbs those substances, or those substances stick in it, we also have hairs that line our entire airway called cilia. And those cilia are all waving up back towards your mouth. So it kind of is always pushing the mucus back up towards your mouth. And the vast majority of the mucus you produce, you actually just swallow, and you know, it enters your stomach. That's why sometimes when people have a really bad upper respiratory tract infection or sinusitis and stuff like that, and they have excess mucus production, they can feel nauseous because they're getting so much extra mucus down into their stomach. And that happens a lot of times to kids. And when they vomit, you'll see it's kind of like a streaky vomitus, you know, and sometimes parents get nervous about it because it's not a normal looking, you know, vomitus. And then the last thing that happens is that if that mucus dries up, it can develop what's called a mucus plug. So that's what I just want to talk about for a second. Mucus plugging is very, very dangerous. Now, it doesn't all the time happen in asthmatics, right? It's not as regular. It's more of a risk in like cystic fibrosis patients and stuff like that, but those are not, you know, so common for us to have to treat. So what happens is you see here in these dissected open bronchioles of people who unfortunately died, probably of mucus plugging, that the mucus developed into a hard plug so that no air was able to get past it, right? So you see here and here, and this is an exaggerated mucus plug that was, dissected out of, obviously, I would assume a cystic fibrosis patient that probably died. But why I want to bring it up is that in EMS, we don't use a lot of humidified oxygen. So I think you know that the oxygen in an oxygen tank has zero humidity in it, right? Zero. And we're not designed to breathe air with no humidity in it, right, as a human being. That's why sometimes you'll see in the winter, it kind of gets hard to breathe. It hurts to breathe and stuff like that because in the winter, the humidity level tends to be lower. So when we have a respiratory patient, well, let's do everything. Pediatric patients in general probably would benefit from humidified oxygen, okay, because they're breathing faster and they tend to dry themselves out, okay. Respiratory patients, with the exception of, say, a pulmonary edema, congestive heart failure patient, so whether it be a COPD or whether it be an asthma patient, would benefit, or a cystic fibrosis patient, absolutely would benefit from humidified oxygen. So the humidifiers we use today are, one-time use disposable humidifiers. They only really work in the ambulance, and it's a pretty simple procedure. If you don't know how to use it, Pete or someone can show you, how to use it. But that would be a great benefit. And you've never seen somebody getting oxygen in a hospital where it's not running through a humidifier. So it's just something EMS does. And we kind of get away with it in Rockland because we have such, most of the time, short transport times that we kind of argue that it's not going to affect the patient. But it's better for the patient, especially the respiratory patient, to get humidified oxygen. Now, just to recognize that it's only going to work if you're giving nasal oxygen, right? If you're using a CPAP or a non-rebreather, it's not going to work, okay? Nebulizer, you don't need it because it's already being moistened, but it's when we're using nasal oxygen. And more we're going towards nasal oxygen because the need for a non-rebreather is now medically being proven very rarely needed. If you have somebody with a pulse ox below 94%, and you put them on some nasal oxygen, you can't get it up above 94%, then maybe you would go to a non-rebreather. But, the need for high concentrations of oxygen are not needed, just because, again, we try not to do anything that's not normal for the body. So they're saying now a normal pulse ox, state's still saying 94%. The Heart Association in the ACLS and PALS classes went down to 92%. But anything really, as far as our protocol goes, above 94% is considered normal. So there wouldn't be a need for supplemental oxygen. Obviously, if the patient feels short of breath, you would still give them oxygen, even if they were sat in at 98%. You could try to explain to them their oxygen level is perfect in case it's just an anxiety type of thing. But we try not to withhold oxygen from people who are saying that they can't breathe, because from a medical legal standpoint, if a patient's complaining to you, they're short of breath and they can't breathe, you really can't defend yourself by saying, well, state protocol says 94% or higher is fine, because there are certain circumstances like a small pulmonary embolism or something like that, where the patient may have the sensation of being short of breath, but yet their pulse ox may not be real low yet if it's a small one. So if somebody really says they're short of breath, I wouldn't get into the debate with them. I'd put them on some low flow nasal oxygen and see if it helps. So again, the humidifier really only works efficiently with the nasal cannula. Okay, so we know there's all different types of triggers, right? It doesn't really matter to us. It just matters how controlled an asthmatic is. In other words, asthmatics take medications every day to prevent them from having an asthma attack. That's called their maintenance drugs. And then if they have an emergency, they usually have their emergency inhaler, which, just like what we use is albuterol, that's what they have in their meter dose puffer type of device that they squeeze in their mouth is albuterol. So that's reserved for the situations where, their maintenance drugs didn't prevent them from having the asthma attack. Now, the other thing we know about asthmatics is that they don't tend to call immediately, right? As soon as they feel like they're having an asthma attack, it's pretty rare for asthmatics to call. Most of the times they try to treat themselves in the house. So by the time they choose to call us, if they need to call us, if they're not successful treating themselves, it's usually, an hour, 2 hours into their asthma attack, if not more, and they're usually, worse off. So it's not like you're usually going to get an asthmatic and you say to them, how long have you been having trouble breathing, where they're going to say 10 minutes. It's usually more like 2-3 hours. So just something to think about. Now, signs and symptoms, obviously the most common sound a lung sound that we hear in an asthmatic is called wheezing. And again, that's typically starts in an asthmatic is what we call an expiratory sound, that we hear it when they exhale versus inhaling. So when you're listening to lung sounds, what's always good is to kind of control the patient's breathing by you telling them, breathe in now, breathe out now, breathe in, breathe out, right? So you know what phase of breathing. And, after you do lung sounds long enough, you'll just know by listening. But in the beginning, you say, okay, take a deep breath in, take a deep breath out. So normally what happens in an asthmatic is they start out with expiratory wheezing. And physiologically, the reason why is that when we breathe in, that's considered the active phase of breathing, right? Our muscles are contracting, our diaphragm, our intercostals, and we draw in air with a lot of force. So even though the bronchioles are narrow, because we're drawing in air with a lot of force, we actually dilate them and we don't get the whistling sound. But when you exhale, that's passive. That's just the muscles relaxing back to their normal size or normal shape. And that doesn't move a lot of air. So now the air being forced through those narrow bronchioles is not going through with a lot of force, so you get a whistling sound. So when you first listen to lung sounds in an asthmatic, you expect to hear expiratory wheezing. If you actually hear inspiratory and expiratory wheezing, that means they're further into their asthma attack. In other words, they're tighter. And even though when they breathe in, they should be dilating their bronchioles, they're not. So that's a sign that they're further along, or worse, tighter, so to speak. And obviously, the worst sound would be that you don't hear anything. It looks like they're trying to breathe, and they're not going to be probably conversing with you at this point. But in other words, they're so tight that they're not moving any air. Now, obviously, they're going to be breathing faster, so that's tachypnea, right? They're going to be tachycardic because they're scared. They feel like they're suffocating. Again, they may get cyanosis, may not. It really depends on how far along they are. And the reason I have cough down there is a type of asthma called cough variant asthma. So variant means it's not the typical presentation. And in those asthmatics, instead of wheezing, they cough, but it's not the hacking cough of a chest cold. It's actually like a weak, ineffective cough that you've all probably heard if you've ever given albuterol to a patient. So when we start, giving albuterol and we start to open them up, they do this kind of like weak cough, and it's like like they can't catch their breath type of cough. So that's what happens in cough variant asthma. It doesn't matter clinically a whole lot because it's still treated with albuterol. So just like you would treat the asthmatic with albuterol, you can treat, the wheezing asthmatic with albuterol, you can treat the coughing asthmatic with albuterol. Okay, so this would be somebody telling you, have a history of asthma, and they may even know that they have cough variant asthma. You can still treat them with albuterol. Okay. Now, some other things we see is accessory muscle use. So the two main muscles of breathing in an adult are your diaphragm, right? It separates your thorax from your abdominal cavity, and the intercostal muscles between your ribs. Okay, so you have intercostals between your ribs. You also have them going down over your ribs. So most of us at rest, like right now, we're just using our diaphragm. And then if we were exercising, we'd be using our diaphragm and intercostals. So for us, accessory muscles would be anything but those. So you may see the stomach working, you may see the neck muscles working. In kids, they primarily use just their diaphragm, probably to about 6 to 8 years of age. So in kids, if you see a lot of intercostal retraction, you've all seen those pictures of those kids having trouble breathing and the space between their ribs is kind of tugged in. So if you see intercostal retractions, that would also be a sign of accessory muscle use. Sometimes in COPDers, the emphysemic COPDers, the ones that tend to be very thin because they burn so many calories, when they're trying to breathe, you can also see that intercostal retractions in them. Okay. Another good sign of an asthmatic or any respiratory patient that's really having a lot of trouble breathing is that they can't speak in full sentences. So they're speaking to you like in one-word sentences because they have to get a breath in between. Anxious, right? Most patients who are severely in respiratory distress, besides not being able to speak in full sentences, they're going to be very anxious because of the hypoxia affecting their brain. Again, we said with the asthmatics, they have that prolonged expiratory phase. It actually takes 2 to 3 times to exhale in an asthmatic as it does to inhale. So, it takes a much longer period of time, again, because it's just harder for them to get the air out. And then, patients just after a while learn to find it by tripoding, which is kind of supporting their body weight on their arms, pressing like their arms down on the seat of a chair or the arm rests of chairs, helps them in breathing a little bit. And physiologically, what happens is that they actually allow their diaphragm to come down a little further, so they get a little more air, a little more tidal volume with every breath by doing that. And in pediatric patients that are breathing, real hard, you'll even see the skin on the side of their nostrils will flare as they start to breathe because they're sucking air in with such force. Now, again, with asthmatics, because they're breathing so fast and because muscles are what allows us to breathe, right? Our brain is monitoring the level of carbon dioxide and oxygen, telling the muscles how fast to move our chest to breathe. But ultimately, it's muscle movement that's causing us to, move air in and out, the physical part of it, the mechanical part of it. So that if you decided to lift weights, and we're doing arm curls constantly, that at some point you just can't lift anymore, right? Because what happens is that your muscles revert from aerobic metabolism, which is making energy with oxygen and sugar, to anaerobic metabolism, which is making energy without a lot of oxygen, right? So normal metabolism, aerobic metabolism, we burn that sugar and oxygen. We make a substance called ATP, adenosine triphosphate, which is our energy molecule, and everything works perfectly. And the waste products that are generated, right? Because anytime you burn something, you're going to have a waste product. So when you burn that oxygen and carbon dioxide in the good metabolism, the aerobic metabolism, your waste products are carbon dioxide and water, which is very easy for the body to get rid of, right? We exhale the carbon dioxide and we reabsorb the water, so it's no issue. What happens is that when the muscles continue to be used in a low oxygen environment, like a respiratory problem, like asthma, right, they revert to anaerobic metabolism. And now they still make some energy, right? So the patient's still, somewhat able to breathe. They don't breathe as deeply and as hard, so their tidal volume drops. And the issue is that the waste products, are lactic acid. So lactic acid, when it gets into a muscle, just like, when at some point when you had your arms above your head working or you were exercising, lactic acid eventually makes a muscle fail and not work. So they go into this state called respiratory muscle fatigue, where it looks like they're breathing, right? Because they're still trying to breathe, but they're actually only moving air in what's called the dead air space. So the dead air space is everything above your alveoli. And obviously, to have gas exchange, you have to get air down to your alveoli, because around the alveoli, the air sacs are the pulmonary capillary network, and that's where you get the exchange of oxygen and carbon dioxide between the bloodstream, right? So the carbon dioxide leaves the bloodstream and the patient exhales it out. The oxygen leaves the alveoli, gets into the bloodstream, and the body circulates it around. So you have a decreased tidal volume. So just as an example, a normal respiratory rate is 500 mLs, right? 400 to 500 mLs. I'm not respiratory rate, I'm sorry, tidal volume. So that's about, size of water bottle, the typical, I think it's 8 ounces or 16 ounces actually of water. It's about, 500 mLs. So that's about the air we move in and out with one breath at rest, okay? So out of that 500, about 150 of it is not available to get down to the alveoli because it has to fill up the space from your nose, okay, to your bronchioles, and the next breath would push that 150 down. But out of 500 that you breathe, only 350 gets down to your alveoli for gas exchange. Now, if you have respiratory muscle fatigue, right, if you've been breathing too hard, and instead of moving 500 mLs of air, you only move 300 mLs of air, just for an example, 150 is still getting stuck in the airways, right? It's the dead air space of the airways that's not available to the next breath. So that really only 150 is available for gas exchange. So now the problem is that obviously the CO2 level starts to rise, the oxygen level starts to drop, and you're going to see at this point where the patient's mental status starts to decrease. So you've all treated respiratory patients. They've probably been all wide awake, anxious, may not have been cooperative, but they were anxious, wide awake, and they were struggling to breathe. If you have a respiratory patient that's starting to fall asleep, that their head is resting on their chest, they're falling over, they're going supine or prone or whatever, that's not a good sign. A respiratory patient will never try to lie down because it's harder for them to breathe. So if you get there, that means that patient's moved into this respiratory failure state, right? This respiratory muscle fatigue state, and passively giving them anything is not going to work. So like putting oxygen on them at this point is not going to work because they're not breathing deep enough. Try to stick an albuterol treatment in their mouth is not going to work. So whatever you're doing at this point, you have to kind of force into them, which means you have to bag them. You have to use the bag valve mask. That's the only way you're going to get air and oxygen down into them. Now you can use CPAP before they kind of nod out to prevent them from going into this failure, right? In other words, if you have a patient who looks like they're struggling, but they're still wide awake, when you put them on CPAP, that helps to increase their tidal volume. So that prevents them from developing this respiratory muscle fatigue, this respiratory failure. But once their mental status decreased, that's one of the contraindications. If you remember all the contraindications to CPAP, that's one of the contraindications to CPAP is that a patient has to have a, a mental status, Glasgow Coma scale of above, 14 or above. So 15 is normal. 14 is probably where we're all out this moment because we're tired. So they have to be kind of wide awake and willing to work with the CPAP. So if they're already starting to nod off, they're definitely below 14. So you have to use the bag valve mask at that point. Okay. Okay, so status asthmaticus is the worst stage of, or the worst type of asthma. So status asthmaticus is a patient who is not breaking with albuterol, with bronchodilators. So that normally when we have an asthmatic patient and they're able to breathe deep enough, okay, the albuterol does a good job. Now, I know on a BLS level, you're just using albuterol, but most of the times albuterol treatments are mixed with a second medication that works on the airways a different way. They were going to put it in the protocol this time around, and somehow or another didn't make it. I would assume the next time there's a protocol revision, you will be giving both albuterol and ibuprofen, Atrovent, to your patients. That's called a duaneb. If you ever hear them say duanebs and stuff, that's kind of the standard treatment. And you don't have to fear, using albuterol on patients, because what happens in the hospital is they get back to back albuterol treatments, right? Until they're 100% better. They have no, complaint of trouble breathing whatsoever. So we're allowed to give up to 3 in the field. And you got to figure it's going to take you probably 5 minutes to get an albuterol treatment in. So maybe, depending on where you're going, you may have time to give all 3. But most of the times we get 1, maybe 2 albuterol treatments in just because of our shorter transport times. But this status asthmaticus patient is probably not going to be able to use it. This is like a respiratory arrest, pre-cardiac arrest type of patient. They're so tight. And it could be, that maybe they sat in the house trying to treat themselves for a long period of time by the time we get them. So to address that, when they made the new protocols that came out, they include the Epi Pen. We'll talk about that in a second for use. So again, we're talking about that we need to get air down to the alveoli. We know that the alveoli are the air sacs, but they're not just like one big sac. They're actually sacs with walls inside of them that partition them into multiple rooms. And that's important because where the capillaries run through are actually the walls. So the more surface area, the more walls you have in an alveoli, the more area of gas exchange you have to be able to take place. That's actually the problem with emphysemics. In emphysemics, the physiology of the, or the anatomy of the walls changes, and they really get like one big sac that gets very floppy. So it's hard for them to inflate it with each breath. And because they have less walls, they have less areas for gas exchange. They try to compensate by developing more red blood cells. The body always tries to help us, but developing more red blood cells is a short-term fix because you're not going to be able to repair your airway. And the problem with having more blood cells in your blood is you're more likely to clot. But anyway, the yellow tubes are the bronchioles, the terminal bronchioles going into the alveoli. And this is showing you an incomplete, alveolus or single alveoli with the capillary network wrapped around it, but it's also wrapped throughout it. And again, this is where this is the whole purpose of getting air. We need to get air down into here so that the oxygen can cross over into the bloodstream and the carbon dioxide can leave the bloodstream to be exhaled, right? So that's where you really need to get. And, getting air into your bronchioles is not good enough for gas exchange. It has to actually enter into the alveoli. Okay, so now what can we do for these patients? So they did change the protocol, right? So, I mean, I know a lot of you did the protocol update. I got your CME papers and stuff like that. So the old protocol said that to use albuterol for EMTs, the patient had to be between the ages of 1 and 65, had a history of asthma, and so on and so on. So that was kind of silly. It didn't really have any, reason why we'd exclude patients under 1 year of age or over 65 years of age. And we know that wheezing is not always the only sound in an asthmatic. So the new protocol has no age limitations on it. And it says any patient, okay, who's having respiratory distress can be given albuterol. So you can now use albuterol in COPDers, anaphylaxis. We'll talk about that at some point, when we do anaphylaxis, because albuterol is not the first line treatment in anaphylaxis. Epi is, but maybe after you gave some Epi, if they just have respiratory complaints, you could try some albuterol. But in asthma, albuterol is our first line drug. So pretty much at this point, everybody, has gotten training. Years ago, it was an addition. So there were a lot of EMTs that were never trained in it. So there had to be in services and stuff. But nowadays in EMT class, everybody should be trained in it. They should be trained on using a nebulizer. and everything like that. They upped the amount of dosages from 2 to 3. So now you can give up to 3 doses. And the protocol actually says that you can call medical control for permission to use even more. So, we're fortunate that we're in a county where we can get to hospitals pretty quickly, but, you can go upstate New York and they could have an hour plus ride to a hospital. And that's not counting, even for weather. So, there has to be an ability. So, but again, 3 doses would be standing order on your say-so. And if you need to go beyond 3, then it would be a medical control option that you'd have to call for. Okay. What is albuterol? So albuterol is a very rapid acting bronchodilator. It does have some side effects. Okay. So it does make people feel nervous and jittery and probably a little tachycardic and stuff like that. Hopefully those are mild symptoms compared to the feeling like you can't breathe. But I've had patients, in my years of doing this who've said, please, don't give me the albuterol. It makes me feel horrible, which is why they didn't take it themselves in their house and why they had to eventually call us because they didn't make themselves feel better. And there's really, no alternative. I mean, if they're refusing to use it, they're refusing to use it. There's nothing you could do. You can't force them to use it, but you have to explain to them that, there's no other drug that we can give you, okay, that's going to make you feel better other than the albuterol. Because if we had to revert to epinephrine to treat them, they're going to feel 100 times worse. I mean, if they felt tachycardic and jittery with albuterol, they're going to feel, 10 times worse with epinephrine, but we'll talk about epinephrine in a second. So albuterol comes prepackaged. Years ago, there was like a bottle of it with a medicine dropper and you had to draw up the right amount and everything like that. But now it comes prepackaged. Everybody has a different way that they buy it prepackaged, but it comes 2.5 milligrams and 3 mLs of normal saline. And that is the amount that you give a patient, whether they're peds or adult. Okay. There may be in pediatrics, families that have a different drug called Xopenex and that they don't want their kids to get albuterol. So, technically Xopenex is not in our pharmacology, that we use. So you would have to call, if they were insisting, this patient had to be transported and only given Xopenex, you'd have to call medical control and get permission from them. It's no different than what you were doing as far as the actual technique. It's just that Xopenex tends to make kids less tachycardic. And, it's just a chemically altered version really of albuterol. It's just a bronchodilator. But, it's probably 5 times, 10 times more expensive, which is why some insurance plans only pay for albuterol and other insurance plans pay for Xopenex. As far as the nebulizer goes, most of the times we run our nebulizers at 6 liters per minute. They can be run as low as 4 liters per minute, but we run typically ours at 6. It serves no purpose going above 6 because you'll, just go through the albuterol too quick for the patient to breathe. So, 6 liters per minute would be fine. Encourage the patient, if they can, to breathe deeply and hold it, maybe every 5th breath or something like that, to, take a nice deep breath and hold it. And they'll actually, as it starts to open them up again, they'll make that little weak, ineffective cough, which tells you that it's, starting to open them up. You don't want them to just breathe real quick and shallow, because if the albuterol doesn't get down to the alveoli, it's not going to work. It has to get into the alveoli, cross over into the bloodstream to cause this whole, bronchodilation type of thing. Again, we can give up to 3 doses. So after your first one, you can give 2 more. I think everybody at this point knows how to put, the nebulizer together. But if you don't, I can't really show you pretty well on the Zoom. But I'll be happy to show you in person and stuff like that. Or you could ask Peter. Anybody who's been doing it for a while. Epi Pens for asthmatics. Okay, so up until this point, EMTs could only use the Epi Pen for anaphylaxis, and it is still a standing order in anaphylaxis. You can give up to 2 Epi Pens if you need to in anaphylaxis. The reason they put the Epi Pen in asthma, and just so you a little background, before there was albuterol, the only drug we gave asthmatics was Epi. We gave them a subcutaneous injection of epinephrine, every single patient who had an asthma attack. The reason we got away from Epi and went to albuterol is that Epi was much more taxing on the heart than albuterol was. So it's just strictly, what accomplished the task, which was bronchodilation with the most minimal side effects. So albuterol is better. It does cause some cardiac side effects, but not the way epinephrine does. Epinephrine is kind of a huge, heavy load on somebody's heart who, and again, if they're hypoxic because they're having an asthma attack, it's not the ideal way to treat them, but that's all they had years ago. So, that's what we used. So they put it back into the protocol for EMTs as a medical control option, which means that you cannot give it without calling for permission. And the reason why is it is possibly damaging to a patient, but It's the only life-saving treatment in that asthmatic who becomes in that respiratory muscle fatigue where they're not breathing deeply, because if they're not breathing deeply, the albuterol will not work. Okay. So if you have a patient that's barely talking to you, keeled over to the side, you know, hypoxic, pulse ox is in the 70s, 80s, just looking like they're about to die, albuterol is not going to work because they can't suck it in. There's nothing you could really do. You're trying to bag them. You can't get chest rise because they're so tight. That's when you're going to call medical control and say, you know, I have an asthmatic patient. Family says he's been having trouble breathing all day. He's unresponsive, barely breathing. We can't bag him. We can't get chest rise. You know, he can't use the albuterol because he's barely conscious. We'd like to go ahead and use the Epi Pen on him, you know, and I always say as per our protocol, because remember, the emergency room doctors, even though they're supposed to know the protocol, do not know the protocol. And if they did know it at some point, they don't remember it. So when you say as per protocol, you're basically telling them it's okay for us to use it. We just have to call you, you know, to run it by you. And it makes them a little more likely to allow you, you know, to use it and stuff. But you do need medical control's permission. So you just can't give it on your own say so. Okay. And you use it pretty much the exact same way as far as dosing and amount of doses and everything as anaphylaxis. So it's 2 doses. You can give up to 2 doses. Again, you have to call for both technically, right? Or you could say to them, you know, if they say, fine, go ahead and give it. And you say, okay, if he's not getting better, can we give him the 2nd dose? They may say yes, or they may say call back. You know, it really depends, but you could try to say, okay, you know, if they're not getting better, is it okay also if we give them the 2nd dose in 5 to 10 minutes as per our protocol, right? So you're kind of telling them this is what we are allowed to do. The dosing of it, again, is just like anaphylaxis. You go by weight. So it's basically, you know, the 66 pounds type of thing. Where is it? It's over here. Whoops. I don't know where it went. Here it is. So it's 30 kilos or 66 pounds or greater would be the adult patient. And you would use the adult pen, which is 0.3 milligrams. Now I know in SOAC, you still have Epi Pens. You're not using check and inject, so you don't have to worry about drawing it up. But in peds, again, you would go to the pediatric Epi Pen, which has 0.15 milligrams, which is actually half of the 0.30. This is really, you know, in decimal places, it would be 0.30 milligrams. And that's for patients that weigh under 66 pounds. Okay, now epinephrine, this is the issue with it. It works very good for bronchodilation, very potent, very quick. The problem is that it increases something called the myocardial oxygen demand. So myocardial oxygen demand is a fancy way of saying how much oxygen does the heart need at any given time. So us sitting here right now, our myocardial oxygen demand is very low. If we were running, it would be higher, right? So it just depends on the level of exertion in your body. The problem is that when you give somebody epi, you're raising their myocardial oxygen demand to the highest levels, right? I mean, you know, it's as if you were running full speed, you know, for a while. And since they're having an asthma attack, they're probably a little hypoxic. So you have a mismatch between the amount of oxygen the heart needs and the amount of oxygen the heart's getting. And that can trigger, you know, ischemic chest symptoms. You can get chest pain, you can get EKG, you know, rhythm disturbances and stuff like that. But obviously, if you don't treat the asthma, they're also going to get bad. So it's one of those things where, you know, 50-50, you cross your finger and hope it's going to make them better. Just like in anaphylaxis, sometimes we give people epinephrine and they have chest pain. But if you didn't treat the anaphylaxis, they would die from it. So, you know, if you truly have a patient that's at the end stages having an asthma attack, then you would call medical control for permission to be able to use it. Okay. But again, medical control option only. And that's really pretty much everything with asthma. So does anybody have any questions, concerns, or anything about the asthma patient? Okay, so I'm going to just get rid of this one and bring up the abdominal, and then we will call it a night. Okay. Okay, so this is not me. Peter volunteered to pose for it. So, okay, so in the EMS world, there's really nothing we could do for abdominal emergencies, right, except transport them to the hospital. We have no real treatments, no real cures. We do have a medication on the ALS level that helps them with nausea and vomiting, but it's not curing the problem, it's treating the symptoms. So the vast majority of times they need, you know, they need transport to the hospital. But the state does have 1 hour. It was 3 hours in the old CME requirements, but now it's down to 1 hour. They do have 1 hour of abdominal and gastrointestinal. So I just picked picked a couple that, we come across or that would be, interesting if we did see them talk about. So the first one I picked about is what they call the abdominal aortic aneurysm, or the AAA, right? So a very life-threatening situation. So your aorta is your largest artery, originates off your left ventricle, okay? It comes off your left ventricle, it goes up into the aortic arch, comes behind your heart, in front of your spine, and travels down through your chest, down into your belly, about the level of your belly button, just maybe a little below it, your belly button. And then it bifurcates or splits into your iliac arteries that go down into your legs, go down to your femorals, into your legs, right? So if it's the largest artery right off your left ventricle, it's also the artery exposed to the highest pressures. And because of that, it can develop weakened areas inside of it that cause it to bulge and have an aneurysm or a weakened area, right? So if you see up here, what basically it's showing you is that, the aorta pumps up, okay, into the left ventricle pumps up into the aorta. So your left ventricle is really down here, but the way it pumps is actually up into the aorta. The aorta arches and goes behind the heart, okay, down throughout the chest, down into the abdomen, and then it bifurcates down into the iliacs. Off the arch of the aorta, right, are your three large arteries that give blood to your upper extremities. So you got your subclavians, and then you have your vertebrals and carotid arteries that bring blood up to your brain. So this one, here, what they're trying to show you is that, they developed this bulge. Now we'll talk about what causes the bulge. And this is, again, a CAT scan. This is actually a pretty good CAT scan of an aneurysm. Your aorta is about the size of a 5/8 inch garden hose, maybe 3/4, depending. Males might be a little bigger. Okay. But what could happen is any high pressure hose, just like a tire or anything like that, if the inner layer gets a weakening in it, and we'll show what happens, it can develop an outer bulge in it. And obviously the worst consequence of an aneurysm would be that it actually ruptures. And that most of the times is fatal, okay? But the other thing that could happen as it starts to dissect, okay, is that it could travel downward. When you have an abdominal one, it could travel downward, okay, and cause lack of blood flow into the blood vessels. And I'll show you that in a second. Okay, so most people have abdominal aortic aneurysms. It's been growing for a while, months, years, and stuff like that. It's only when it gets very large that there's symptoms. It's very rare where it comes to the surface like this. In fact, if I saw a patient, who had a bulge on the surface of their abdomen, I would assume it's a hernia and not actually an aneurysm. So how would you clinically tell the difference? A hernia would not have a pulse because it's not a blood vessel. All a hernia is an abdominal organ, typically an intestine, that protruded through a weakened, abdominal wall muscle. Okay, a aorta, because it's obviously an artery and a quite big artery, right? The largest one will have a pulse in it. So if you felt that bulge and there was no pulse on it, then it's probably just a hernia. If you felt that bulge and there was a pulse, like this gentleman, then it would be an aneurysm. Now, where it rises to the surface of the abdomen is pretty rare. Okay, so that's a pretty rare type of situation here. So you see, on the CAT scan how it kind of is showing what happened with this gentleman over here. So what do we see? So the most definitive sign and symptom, I guess, would be that you can actually palpate the aorta, the pulsating mass of the aorta. But typically what people have is a sudden onset, okay, of very continuous pain that they sometimes describe as tearing. And the reason they feel it as tearing is if you look over here, as the walls of the blood vessels start to separate, the aorta, arteries have three walls, and what's happening is the blood is working its way between the inner and middle wall, and that's what's causing the dissection or the separating of the walls. They describe it as a tearing pain. Now, that pain could be described as back pain because the aorta runs right in front of the spine. So sometimes people don't call it abdominal pain, they call it as back pain. Or if it's in their chest, they say, I might be having a heart attack because they feel pain in their chest. But if they describe it as a tearing pain, that's much more typical of a aneurysm than it is of a heart attack or anything else. Remember, the rule out of like kidney stones in somebody, right? The rule out you would always think in the back of your mind is, could it be an aneurysm? Yes, it's probably kidney stones. Patient tells you have a history of kidney stones. The patient tells you it's painful when they're urinating. The patient tells you there's blood in their urine. Sounds like kidney stones, but the rule out, the possible alternative diagnosis is always an abdominal aortic aneurysm when somebody has lower back pain. Okay. Now, what happens in somebody who has an aneurysm? So here's a nice clean arch of the aorta. Now, remember, we're talking about it happening way down here, but the only picture I could find is showing it in the arch. So nice clean lumen, but now the guy gets some vascular disease. Just like, you can have vascular disease in your heart or something like that. They get some vascular disease and they get a little nick on the inner wall of the artery. So you see there's a little nick there. Remember, this is high pressure, right? It's right off the left ventricle. So what it starts to do is the blood starts to work its way between the inner layer, right? That's where the nick is, and the middle layer. And it makes an artificial pathway, an artificial lumen now that it's trying to pump blood up into. And that's the dissection, that's the tearing pain that starts to develop in these patients. Now, one of the risks that could happen is that because there's blood up in here, but it's not really circulating, it could clot off, right? You know that blood that is not circulating develops into a clot pretty quickly. So you could start developing small clots in here. And if blood flows in here and flushes the clot out into the main lumen of the artery, it's going to float somewhere. So in this situation where we're talking about in the arch of the aorta, what's going to probably happen is either one of their arms is going to go numb because it's going out into the subclavians, okay, or it's going to go up to their brain, they're going to have a stroke. But since really the class was supposed to be on abdominal ones, it's actually going to go downward, right? And we said that at the bottom of the aorta, it splits and goes down into the iliacs, and it'll travel down the iliac into the femoral ones, into the femoral ones in the leg, and all of a sudden that patient will get a cold, numb leg. If not, now, not every patient has abdominal aortic aneurysm throws a clot, but if you had somebody who said to you, I've got some back pain and my leg went numb and cold, your rule out diagnosis is a AAA, is abdominal aortic aneurysm, until proven otherwise. Now, what causes people to use it? So just like smoking causes vascular damage in the heart, it causes vascular damage in any place. People who do have coronary vascular disease, so anybody who's got plaque deposits in their arteries are more prone to this. Infections or inflammations of their arteries. High blood pressure obviously makes the pressure going through the arteries higher and more likely to lift it up and tear it. Okay. And what are the complications? So the dissection, where it starts to make that artificial pathway, obviously rupture, okay, clots and stuff like that. Those are all. So the worst complication, or the worst, I guess, manifestation of an abdominal is one that ruptures. Most of those patients pretty much die before they ever get to the hospital. And I'll show you some of the things they could do for them, but most of them typically die before they get to the hospital. Okay, so what do we do for assessment? So good history taking, right? So, sudden onset, excruciating lower back pain, again, because we're talking about abdominal, tearing sensation and stuff like that. We want to palpate for the pulsating masses. Now, when you palpate for a pulsating mass on the abdomen, it's different than normally palpating the abdomen. So normally when we palpate the abdomen, we're kind of going like this, and we're pushing laterally to medial, right? From the sides towards the center. If you do that, you're not going to actually feel the pulsation. So what you actually have to do is trap the artery between your two hands. So you see here how they're kind of manipulating the skin, manipulating the aorta towards the other hand. So they're trapping it. So that's one way to do it, okay? The other way to do it would be reaching downward this way. And you may have actually, if you went for a physical and you're a little older and your doctor was doing a good physical, you may have actually, felt him or saw him, her do that to you, okay? So like if they're ever trying to trap an organ, that's the way you do it. The way we were taught to palpate is fine if there's blood in the abdomen or pain in the abdomen, stuff like that. But to actually trap an organ, like if they're checking your liver to see if your liver's engorged or something like that, it's typically how they would palpate. Okay, so that would be how we would palpate if we're thinking. Now, if you do feel a pulse, that's it. Nobody else needs to palpate. You don't need to keep on touching it or anything like that, because we don't want it to, rupture. Limb ischemia would be another good sign. Now, they say, I've never had it, I've had a couple aneurysms, but they say that there's going to be a difference in the pulse strength and the blood pressure. So if we're talking abdominal, it would be in the legs. And if we're talking thoracic, it would be in the arms. So again, if you notice when you're checking their pulses and their blood pressures and stuff like that, there's a difference. That's also considered. That's typically when there's a dissection developing, that there would be a difference in those strengths. And obviously if a clot throws, there would absolutely be a difference, because that leg that gets the clot is not going to have the same blood flow. So there would definitely be a big difference. Now in the hospital, they use ultrasound. Probably at some point EMS wise, because there's a lot of EMS services already using ultrasound. At some point we'll have ultrasound on the ambulances, paramedic units and stuff like that. You know, it's another good diagnostic tool. Again, with our short transport times, I think probably no use in Rockland County. But if you were someplace where you had a longer transport and maybe you needed to go to a trauma center, or maybe you needed to go to a, you know, a higher level hospital, it may help you guide your decision to go to that higher level hospital, even if they're a little further away, you know, based on what you find in ultrasound. And they probably are going to have the technology where we could actually send the ultrasound tracings right to the hospital to have them interpreted. So in the hospital, pretty much everybody who they think has an aneurysm is going to get a CT scan. And then if they find something on that, they're going to get what's called a CT angiogram if they're stable enough for the time to wait, where they inject dye in the blood vessel and just makes it easier to read. Now, what do they do for these patients? So the old way was actually opening them up, okay, clamping the aneurysm, so you could see the huge aneurysm. You could kind of make out up here what the aorta should be of size, but they would clamp the aneurysm above and below and graft in a new, I don't know what they make it out of, but let's say Teflon, you know, tube in here. The problem was that, you know, to do this, you have to clamp the aorta. And if you're clamping the aorta, you're depending on where it is, you're depriving blood flow below it. So you could be shutting down the kidneys, you know, and people can't last very long with no blood flow through, you know, through an aorta. So it was always the kind of thing where the surgery to correct it may actually result in, you know, the death or paralysis of the patient. So it was not a great thing. They didn't do it in very old patients. And, you know, older patients, they felt wouldn't even survive the procedure. So they used to do what's watchful waiting, which is do nothing other than, you know, keep an eye on them and stuff like that. You know, there are patients who have fairly significant aneurysms and are not candidates for surgery because of other comorbidities years ago, who didn't die of an aneurysm. My grandmother had a fairly large abdominal aortic aneurysm and lasted like 20 years with it and didn't even die from it. So, you know, that was when they used watchful waiting because she would not have survived surgery. But nowadays, this is probably not the most typical way of repairing it. I mean, it still happens this way. My wife corrected me the other night when I was teaching that both Good Sam and Nyack are capable of doing open repairs and actually doing what they call endovascular repairs. So I somehow lost the endovascular one. Okay, so the endovascular one, I don't know, I lost the slide somehow. The endovascular one involves, they would basically enter into the femoral artery in the leg, just like if they were doing angioplasty for the heart. And they bring a catheter, okay, up to the aneurysm and actually go past it. And they leave in there a stent. But now the stent of a heart attack is kind of a coil that, you know, it's not actually solid. But in this case, they leave a tube, an actual like new piece of hose in the artery, so that blood now travels through the hose and it's not putting any pressure. So it's it's right through this aneurysm, okay, going up into the good part of the aorta and down into the good part of the aorta. So it's actually traveling right inside the aorta and not cutting anything out, but the blood now just goes through the good tube and it's putting no pressure on the aneurysm. And what actually winds up happening over a couple of months is that the aneurysm collapses, okay, back down onto that tube. And from that point forward, blood goes right through that tube and there's no risk of, you know, anything developing at that particular site of the aneurysm. And I guess, you know, I don't know how many patients are prone to getting that in other places. I don't know if they have a way of testing, you know, somehow to see, you know, obviously it's not a pressure test, but I don't know if this, diagnostically, you know, radiology, if there's a way of pinpointing blood vessels that are at risk, but that's what they do. So that is really just like somebody who has a heart attack, you know, and gets stented pretty much within 6 to 8 hours is up walking around. It's the same thing with this procedure, right? I mean, you know, if everything goes according to plan, that patient is corrected, you know, ready to get up and move around. Probably the biggest risk at that point would be that just like in the stented patient in a heart attack, is that, you know, obviously they went into your femoral artery, they put what they call a plug into they make a fairly large hole into your artery to be able to get all the paraphernalia. So they put what they call a plug. It's not really typically a plug, but like a dressing on it. And you have to lay still. I think they make you lay still for 4 to 6 hours with kind of a sandbag holding pressure on it. So the biggest risk of anybody having any of those endovascular procedures coming through the groin would be bleeding. You know, I'm sure it's a very small percentage of people who have that problem, but compared to the disastrous, you know, results of a abdominal aortic aneurysm. Okay, so does anybody have any questions on that? Has anybody ever had a patient that had one? You know, I mean, again, typically the outcomes are not great, but you know, getting them, our treatment would be getting them to, you know, the appropriate hospital as quick as possible. There's not much else we could really do for those patients. Okay, upper esophageal varices. So you've heard about varices. Varices are veins. Okay, they get floppy, get weakened. So you've heard of varicose veins in the legs. You've heard of varices in the rectum when somebody have hemorrhoids. You know, so those are all the same thing, that because they were exposed to excessive pressures, they got kind of weak and floppy. Now, veins only have one wall to them. They don't have three walls like arteries. They're not designed to really experience high pressures because they're veins, right? They're getting blood at the end of the circulation back to the heart. And when they're exposed to excessive pressures, they dilate, okay? And they can even get aneurysms. Kind of varices are kind of like aneurysms in veins. So if you've ever seen like a varicose vein on the leg rupture, they can bleed, you know, fairly significantly. Obviously, they don't spurt or anything like that because there's no pulsation, but they can be, you know, kind of not oozing, but like squirting out blood, you know, fairly significantly, you know, but just not spurting it because it's not an artery. So basically what happens here is that, you know, obviously if they're called esophagogastric varices, is the esophagus. We know the esophagus is the tube that brings food down into our stomach. What happened is that the veins in the esophagus were exposed to higher pressures than they should have been, typically because of liver disease. So it's probably going to happen in the chronic alcoholic that gets cirrhosis of the liver, the hepatitis patient, and stuff like that. Because as the liver gets cirrhotic, it's hard, okay? It's harder for the blood to go through it, so it backs up into the esophagus because the portal vein kind of backs up into the esophageal veins kind of back up into the portal vein. So, you know, you're going to see the pressures become greater in the esophageal veins. So they get these bulges that develop in them. So this is an endoscopy picture, you know, where they go down into somebody's esophagus and they're looking for disease. And this whole dilated, okay, ridge over here is a, you know, esophageal vein that's developing a, you know, varice in it. Okay. Now the same thing. So the center part over here, okay, take out this for a second, but the center part over here is the esophagus. Okay. Now, you know, some of you may know that your esophagus is really a flat tube. It's not typically open. Reason when you see endoscopy pictures is that it's open, they actually put carbon dioxide down there to kind of inflate it to keep it open so they could see where they're going. The reason it's a flat tube is it's also lined with smooth muscle, just like, you know, we're talking about your blood vessels and your lungs and stuff like that. It's lined with smooth muscle that when food enters it, it actually rhythmically kind of squeezes the food downward towards your stomach, and that's called peristalsis. You know, kind of looks like the snake you always saw like on National Geographic, the snake eating the mouse, and you see it kind of moving it down the snake's body. Same thing happens when we're eating food. Okay. So over here, what they're showing you is this bulge over here is actually what they call a varice. This is a vein, okay, that because of higher pressures developed this mushroom-shaped bulge in it, and it could rupture and start causing bleeding. And if it bleeds, yes, it's a vein, but there's no way to put pressure on it. So the patient's going to bleed and bleed. Now, the blood is going to flow down into the stomach, and blood into the stomach will cause the patient to vomit. So now they're going to basically start vomiting up bright red blood, and they can lose enough blood to die, right? They can exsanguinate from a large enough esophageal varice. So this is what you see. Now, you may notice, and I'll show you in a second, you may notice down here, it looks like there's a band on it. So if they can get to it emergently, what they actually do is they have a device, and I'll show it to you in a second. They can drop a rubber band on the neck of it. The neck of it is at the part where it's actually attached to the vein, and that rubber band starts to act like a tourniquet and seals off the varice to prevent any more blood from going up into it. So it kind of strangles it. And eventually the varice will just kind of fall off. A scar will develop, it'll fall off. And, you know, you'll just basically bring it down to your stomach and digest it with your gastric juices and stuff like that. So that's how they would kind of treat it if they could. It's just that when there's a lot of bleeding, they can't see where to go. So they have this basically tube, you know, camera, suction, light and everything, and they got the rubber bands, and they go down. Again, they inflate the esophagus with carbon dioxide. They go down and look for the various different varices, okay? And then they put the device over it, they press a button, and it drops a band on it, okay? Now, in a nice, dry, clean, you know, esophagus, it's very easy to see. You know, the other picture, you could see where it's starting to speckle with blood. There's probably some free blood in here and stuff like that. It becomes a little harder to do the procedure, but that's what they basically do. I'm not sure if they could do it with active hemorrhage and vomiting and everything like that. I would tend to think not. But that's what they would do. You know, if somebody comes in with like complaints that kind of point them towards it, or if they did an endoscopy and they saw it, you know, this is the procedure they would actually do to prevent it from actually rupturing and bleeding and stuff like that. Oh, so it got the slides got out of order somehow. This is the actual device for the esophageal, whoops, not the esophageal, the abdominal aortic aneurysm. So they basically bring this catheter up past the aneurysm, right? And they deploy this, I don't know if the right word is a stent, but they deploy this device that the blood now travels through it, okay? And again, it's not putting any pressure on the aorta, so there's no risk of rupture, okay? So the old way was the open repair. The new way is pretty much like everything in medicine now is endovascular, right? Years ago, you had a heart attack and you needed to have open heart surgery, bypass surgery, and stuff like that with all the possible consequences. Now, 99% of heart attacks, you know, or 98% of heart attacks are treated, you know, endovascularly with stenting, angioplasty and stenting and stuff like that. So again, you know, how do they present? Most of the times, I've never had a patient with esophageal varices who did not know. Most of the times you're going to find out they have a history of liver disease. It could be fatty liver because they're overweight, okay? It could be hepatitis. It could be chronic alcoholism. They have some history of liver disease, okay? So that's the first thing. They probably know they have varices. So it's, you know, it's usually not, they know what's going on and they can point it out to you. The problem is that we don't really talk a whole lot about esophageal varices in EMT class. So, you know, the average EMT, unless somebody else provided some instruction on, you may not even know, you know, what esophageal varices are and stuff like that. But when it starts to get to the point where it's likely to rupture, they're going to definitely have a discomfort feeling in their throat. Again, it's not really in their throat. It's just that the nerves in the area are signaling it, you know, tricking it to think of it. It's going to be hard for them to swallow. When it does start to bleed, they're going to be vomiting up that bright red blood. It is definitely a situation where, you know, when they're vomiting up the blood, your ambulance is going to be out of service. You're not going to be able to clean it. You know, you're going to have a professional, you know, company come in and probably clean it and stuff because the blood will, it's like a horror movie. The blood goes everywhere, you know, and gets into every corner and every crevice and stuff like that. So it's definitely a mess. Okay. Now, there's really nothing we could do, right? I mean, the main thing we could do is warn the hospital. They may not believe us, right? They may not believe our diagnosis of esophageal varices and stuff like that, but warn the hospital, okay, and get them there as quick as possible, okay? You're not going to be estimating blood loss, right? Orthostatic vital signs, again, in a patient who's vomiting up blood is of no use at this point. I mean, if somebody just tells you they feel dizzy when they sit up, you may want to get orthostatic vital signs, you know, comparing their blood pressure when they're sitting versus standing and stuff like that. But calling the hospital, letting them know, okay, preventing aspiration is hard, but suctioning as best you can, okay, oxygen, you know, and stuff like that. Fluids are not going to change the patient's picture because they really need blood. And intravenous fluids like, you know, normal saline, lactated ringers is not blood. Doesn't have the ability to carry oxygen, doesn't carry, you know, clotting factors or anything like that. I mean, it's not going to probably hurt them, but it's not going to, you know, really make a big change. They need to get into surgery, get, you know, get whole blood. And, you know, that's really, so till you get them into the hospital, that's not going to happen. Again, most of those patients, just like with the aneurysms, if they're actively bleeding, are probably not going to have a good outcome. And then the last thing we'll talk about, you know, for 5 minutes, and then we'll call it a night, is appendicitis. Okay, so appendix is a little finger-like projection, okay, kind of where your small intestine and large intestine meet, okay? But time the food gets to that point, it's traveled through your whole small intestine, which is 20-something feet long, just not big in diameter. And most of the important nutrients have been drawn out of it and stuff like that. So at this point, it's kind of, you know, fecal matter. I mean, there's some water that may be drawn out of it. I think there's some vitamins that get drawn out of in the large intestine, but it's pretty much fecal matter. And sometimes it gets kind of stuck in this little finger, like about the size of your pinky projection called the appendix. Okay. They used to say the appendix had no real role, but they feel now that it does have some role in repopulating your GI tract with good bacteria if for some reason the level of good bacteria fall, and it may have some immune role in it. Okay, so it does have some role, but obviously you can live without an appendix because people who have appendicitis 9 times out of 10 have it taken out. Okay. So again, because that fecal matter sometimes gets trapped down in there, they develop a infection. Okay. And with the infection, there's swelling. And with the swelling, there could be rupture. Okay. So now if the appendix ruptures and spills that fecal matter into the abdominal cavity, right, the space where all your abdominal organs are, you can get something called a peritonitis. A peritonitis is an infection of the perineum, which is the lining that surrounds the abdominal cavity and the organs of the abdomen. Okay. And obviously that kind of infection could lead to sepsis and death. So that's what really comes down to. So the reason I chose appendicitis is that we all learned in EMT class that the sign of appendix is lower right quadrant abdominal pain. And for years, that's what I believed. And it is, but early signs of an appendicitis are actually what they call periumbilical pain. They're not lower right quadrant pain. That's a later sign. So I just always want to stress that if you go to someone who says, I have a stomach ache, it's around my belly button, okay, I feel nauseous, I feel shaky, I feel like I'm going to vomit, it could be an appendicitis, okay? So we don't want to say, oh, you probably just have the stomach flu and stay home, because it could really be an appendicitis. When the swelling gets worse, then the pain tends to localize down in the lower right quadrant, and that's where they get that lower right quadrant abdominal pain. So earliest stages, periumbilical. When it gets to the ripe stage or when it's swelling, then it's lower right quadrant. And interestingly, when it ruptures, the pain goes away, okay, but the patient's not out of the woods because then there's the risk of the peritonitis. Now, there are people who have appendicitis, okay, and are not treated or choose not to go to the hospital. It may even rupture. They may somehow survive the infection and, you know, they're fine. I just had a friend who had appendicitis, didn't have health insurance, and he, you know, he has extensive medical knowledge and stuff like that. So the CAT scan showed that it was not ruptured, that it was swollen. He went on IV antibiotics for 3 days and then oral antibiotics for 7 days, and it went away. So he treated his infection, right, his inflammation, and he, you know, it went away and he was lucky. Now he's at something, I think, a 60% chance of it redeveloping, but, you know, he's hoping to get a job in the meantime and, you know, have health insurance so that if he has to have surgery, he's not going to go bankrupt from it and stuff like that. So just to, you know, realize that there are some people, you know, who can be treated medically versus surgically, but the risk of rupture and peritonitis is so high that in America, at least, the routine treatment is to surgically remove it. Now, the other important thing is that the quicker if they're going to have surgery, the quicker they get into surgery, usually the better outcome, which means that you don't want them to have to go in and do surgery when the abdomen is all inflamed and red and swollen and everything like that, because then it's likely that they're going to, you know, nick something, or, you know, maybe adhesions that develop with the organs and stuff like that, where if they do it real early before everything's inflamed, they could probably do it laparoscopically with a couple tiny incisions and go in with, you know, the camera type of instruments where they're, you know, looking to see where they need to go without actually opening the person. And that tends to, recovery is much easier and there's less complications and stuff. So, you know, I always try to convince patients to go in, you know, as early as possible. Just one interesting thing about, you know, we had a paramedic that came to work not feeling well, and about 2 hours into the shift was clearly having, you know, appendicitis, and they took him up to, you know, one of our 2 hospitals in the county, and they told him it was going to be a 4 to 5 hour wait for a surgery. So, you know, EMS being what EMS is, we basically drove him to Westchester, right? We said, we're not going to wait 4 to 5 hours to have this guy have surgery. We'll take him to Westchester. So he sat for 18 hours at Westchester before he had his surgery. And so I always say it because just because we go to a bigger hospital doesn't mean they're going to get better care. And the reason he was delayed 18 hours was that they had multiple more severe trauma patients and other things going on that were tying up the OR suites. His appendicitis was not ruptured, so he was not emergent. He was put on antibiotics. He was put on pain medicine. He was hydrated. And, you know, he had his surgery 18 hours later, he was fine. If he had stayed at the Rockland Hospital, he would have had his surgery, you know, much quicker, probably had the same outcome and the same recovery, but been home, much quicker, where he sat, in the hospital an extra day or two because of the fact that his surgery was delayed. So, there are definitely things that are done better at larger hospitals because they do it more frequently, or there's things that can't be done at our community hospitals in Rockland. But, something like an appendicitis, just because, they tell you the patient's going to sit, doesn't mean that necessarily kidnapping them out of the hospital is going to be a better outcome for them or anything like that. Okay. So I think that was it, right? I don't think there's anything else. I mean, again, there's not much we could really do. We do typically give them a little fluid. We do try to, take the edge off their pain. Again, we do have some anti-nausea medications, but, they need surgery. There's not anything that's going to really make them, much better. Okay. Does anybody have any questions on anything we went over tonight? Okay. So just to recap, Jo Marie is going to start helping me with the paperwork. We met this week. I mentioned to her that Steve's coming up, Marielle's coming up, Wayne's coming up. If there's anybody else coming up for recert, please, let me know. We're going to work on a generic email address. I don't know, like soaccme@gmail.com. So that if you start getting CME your own way, or Pete sometimes sends me CMEs from your monthly training sessions, he'll send it to that. And then Jo Marie would have access to it, and I would have access to it. So, if you went to, GEMS or any of those things, and you just give me your certificates. But she will be working on the paperwork aspect of it because I'm not so good with that anymore. And I'll continue to do the teaching aspect of it. So hopefully, be a little more responsive. I know people have waited a while to hear from me and stuff like that. So she'll be contacting you, letting you know, and I'll still be signing the paperwork and, sending it in and all that stuff. But if you hear from her, it's fine to, communicate and anything like that. Obviously, if you have any questions, you could always reach out to me. But that's moving forward. That's how it's going to work. Okay.
Hey, Frank.
Yes. Yes.
We had a case from another crew, varicose veins. Mm-hmm. They tried putting the quick clot 4x4 on it. Mm-hmm. They left him home. They RMA'd him. The guy had to go back to the hospital 3 or 4 hours later. What's, should we have just taken him to the hospital? Does it ever stop?
They probably did the same thing. They probably just put a pressure dressing on him. Again, the problem is, we don't know if they're on blood thinners, right? That could complicate it. Also, we're not going to get a blood chemistry, so we don't know. Maybe their platelet levels are low. So, my theory of EMS is that, we're kind of, our job is to get them to the hospital, not to delay So I very rarely ever agree with patients about staying home. I always try to talk them into going. I mean, obviously, if they're refusing, you can't kidnap them. But I don't know. I mean, I've seen some patients get pretty bad off with varicose veins. So I usually tell them, even if you got the bleeding to stop, there's no guarantee it's going to stay stopped. A lot of times they actually have to go in. They have a medication they can inject in the vein that kind of scars it off and causes it to collapse, so it won't bleed again. So it really probably should be evaluated by a vascular surgeon. I would think. I don't think it's, appropriate for us just to put a pressure dressing on and hope for the best. Because the other issue too is, what if they develop a clot, and then they wind up with a DVT. So I would think it's probably appropriate to transport them to the hospital if they're, amenable to going. If they're refusing and they're going to sign an RMA, you could just point out the risk to them. But I personally wouldn't. I've kind of gotten away from having people stay home. I mean, there's just so many cases. We had a guy recently, shoveling snow the night before, a young guy, I think he was 30, shoveling snow the night before. A day later, he's got musculoskeletal pain when he moves his arms and everything like that. They push on the area, it hurt more. They moved his arm, it hurt more. So it's not definitely reproducible musculoskeletal pain and everything like that. And they sent him in BLS, never did an EKG on him. I don't know why. Shoveling snow always, kind of makes me suspicious of a heart attack. But, he did have a kind of a musculoskeletal story. He was having a massive, massive heart attack, anterior wall heart attack. That's why when they pressed on his chest, it hurt, because it was the front wall of the heart and stuff like that. It was really, an EKG, it would have shown it immediately, because he was having massive ST elevation at the hospital. And that one little test, would have, again, wasn't going to change his outcome, because he was sitting with chest discomfort for 12 hours. So he had a big infarct a long time ago. But, for our standpoint, we definitely didn't do right by the patient. And, you know, the other thing was the patient asked them, am I having a heart attack? And they told them no, you know, and then the patient finds out at the hospital that they had a massive heart attack. So, you know, I tend to think we should transport patients to the hospital. You know, I mean, that's my kind of my theory. You know, I mean, I don't ever agree with patients staying home. So anything else?
Do we have to discuss geriatrics, or that's not on the test this
we kind of
time?
talked about it. So unless you want to, unless after everybody gets off, you want to stay on and we could have a little discussion on it. I just feel like I'm becoming the geriatric patient. So
Unless it's not on the test, it doesn't matter.
there's nothing specific. I mean, the big thing to think about geriatrics is, you know, what they call polypharmacy, which is that unfortunately in America, you know, patients get put on so many medications that could be actual the cause of their problems. So whenever you go on a geriatric patient who was otherwise healthy and had a sudden change in their health status, one of the things I always try to think of asking them is, have you been put on any medications recently, like the last 2 weeks, or have you stopped taking any medications, or have you changed your dosages of any medications? And a lot of times that turns out to be what the problem is. You know, I had a guy who was put on a beta blocker for high blood pressure, you know, and couldn't breathe. So what happened was the beta blocker slowed the pumping action of his heart. And because his heart wasn't pumping effectively, it was backing up into his lungs and he was going into congestive heart failure. So he said, you know, I was put on his blood pressure medication 2 weeks ago. And that's what it turned out to be, you know. So a lot of times you'll find medication type of things is the big problem. The other thing I had not that long ago that I thought was pretty interesting, I never heard it before, was a patient whose thyroid condition was all out of whack. And her insurance company refused to buy her Synthroid, which is not the generic, the trade medication. They gave her some generic one, and for 30 years she was controlled perfectly. And 3 days into taking this generic one, she was a train wreck. And so the only thing she said to me was that I changed my medications not because I wanted to, but because the insurance company refused to pay for the Synthroid anymore. And that's the only thing I could think of. And when I followed up a day later in the hospital, that's what it turned out to be. So when I went to visit with her, I said, well, you just need to let your insurance company know that you almost died from this. And I'm sure they're going to approve your Synthroid, especially when you say that your cousin's a lawyer and you've referred the case to him, because it was inappropriate, for them to change her medication, but they were doing it to save money. So, a lot of times with the geriatric patients, that's what it is. Obviously, the other thing we need to think about is they're always on blood thinners, right? So falls. Pretty much any person that's on a blood thinner, I don't care what they say, should go to the hospital. There's just no way of knowing what's going on with them when they're on blood thinners. And then the last thing, and I'll let you go, is just remember that the most common complaint in an elderly patient having a heart attack is just, I feel weak and tired. It is not chest discomfort, right? I feel weak and tired. I don't have energy. It's called general malaise, right? It's not always that they're going to have chest pain. It could be shortness of breath. It could be general malaise. As we get older, and also with diabetic patients at any age, because of the neuropathies or the destruction of the nerve endings, they don't feel the pain the way somebody younger does. So, if you have an older patient who just doesn't feel right, is tired, it could be, or it could be, remember the earliest, the earliest cause of sepsis in elderly women is a UTI, right? So, I mean, you go to a woman who says, I have a little burning urination, it could be the start of sepsis. So, pretty much anybody, unfortunately, I'd say over the age of 55, and I'm over 55 now, that's calling an ambulance probably has a reason to go to the hospital, so I would just take them. Okay.
Lighten up there, Frank, with the 55 and over, right?
I did it. I'm 58 now, so kind of snuck up on me, but so. Okay, so everybody have a good night. If you celebrate Passover, Easter, have a safe and enjoyable Passover and Easter. Just always, in the back of your minds, just realize we're probably going to get a little bit of a spike in our COVID patients or cases between spring break and Passover and Easter. So probably for the rest of the spring to early summer, just keep your guard up, and hopefully we won't have any more tragedies like we had this week coming up. Okay, so everybody have a good night. And
thank you.
Okay.
Thank you.
Take care. Good night. Good weekend. And
Good night.
Take care, Frank.
Pete, I recorded it. I'm pretty sure. Yep, I did record it. So if anybody's missing it and wants it, just let me know.
Thank you, Frank.
Take care.